All right, let's jump right in. If you're in the medical field, you know that urinary tract infections are, well, they're everywhere. But how we treat the really tough ones, the complicated UTIs, is getting a major overhaul. We're talking about the brand new 2025 guidelines from the Infectious Diseases Society of America. And trust me, these changes are all about getting smarter, faster, and way more targeted.
So here's what we're going to cover. First, we'll look at how the very definition of a complicated UTI is changing. Then we'll get into the much smarter antibiotic strategies they're recommending. We'll also see how cultures are key to zeroing in on the right treatment, and, this one's a biggie, why shorter treatment courses are actually better. And finally, we'll wrap up with what all this means for the bigger fight against infection. Okay, first up, we're redefining what a complicated UTI even is. This might sound small, but it's a huge shift in thinking. The new guidelines are basically saying, stop looking at the patient's charts so much and start focusing on what their body is telling you right now.
So what is that new dividing line? What's the thing that officially bumps a UTI into that complicated category now?
This is where it gets really interesting. In the past, we'd say a UTI was complicated based on who the patient was. Did they have a catheter, a urinary obstruction? It was a label based on their condition. But now, it's all about what the infection is doing now. The new definition focuses on symptoms: fever, chills, flank pain, things that scream, hey, this infection isn't just in the bladder anymore, it's spreading. It's a move from patient history to the infection's current behavior.
To make it super clear, here's exactly what these new guidelines cover. They do include kidney infections or pyelonephritis, and they do include UTIs in catheterized patients, but only if they have those systemic signs we just talked about. What's not covered here? Things like bacterial prostatitis, epididymitis, those are now handled under their own specific guidelines. It's all about being more precise.
All right, next section. Let's talk about choosing the right weapon for the fight. This is all about moving from a brute force, carpet bomb approach with antibiotics to more of a precision strike.
First, we got to understand this term, empiric therapy. This is the doctor's best guess treatment. It's the antibiotic they start you on right away, before the lab results are back that tell them exactly what bug they're dealing with. And you can imagine, making a really good first guess is absolutely crucial.
So, the new playbook for that best guess is a simple three-step process. First, you figure out how sick the patient is. Are they stable or are they septic? That single question changes everything. Because for step 2, if they're septic, you hit them with our broad-spectrum antibiotic. But if they're stable, you can use a much narrower, more targeted drug. Then, step 3 is all about getting them off the IV and onto pills as soon as it's safe.
And why is that last step so important? Well, because getting that IV out has this incredible ripple effect. It means lower costs, shorter hospital stays, and, most importantly for the patient, a much lower risk of complications from the IV line itself. It's just a win-win-win.
This leads perfectly into our third point. How do we go from that best guess to a confirmed kill? Well, this is where the lab comes in. We're talking about using data, specifically from a urine culture, to guide our attack. A urine culture is pretty amazing when you think about it. The lab takes a sample, they actually grow the bacteria that's causing all the trouble, and then they test a bunch of different antibiotics against it to see which one works best. It's like getting a personalized battle plan for that specific bug. And once you have that battle plan, you can do something called de-escalation. You take the patient off that initial broad antibiotic and switch them to the narrowest, most targeted drug that will get the job done. This, right here, is the heart and soul of smart antibiotic use. But what if you could make your initial best guess even better? You can, with something called an antibiogram. Think of it like a local weather report for superbugs. It's a cheat sheet for a specific hospital or community that shows which bugs are common and which antibiotics they're resistant to. It's incredibly powerful local data.
And the new guidelines get really specific here, especially for the sickest patients. If a patient is in septic shock, the most dangerous situation, a doctor should only use an empiric antibiotic if the local antibiogram shows it works at least 90% of the time. The stakes are just too high to gamble. For sepsis without shock, that number is 80%. This is what data-driven medicine looks like.
All right, let's talk about our fourth big update, and this one might feel a little weird at first. For years, the mantra was, longer is better for antibiotics. Well, the new guidelines basically prove that's wrong. It turns out less is often way more.
So what's the new magic number? 7.
just 7 days. For most people with a complicated UTI who are getting better, a 7-day course of antibiotics is the new gold standard. And for some drugs, like fluoroquinolones, it might be as short as 5 days. And this table tells you everything you need to know. When they compared the old 10 to 14-day treatments with the new 7-day course, the results were stunning. The cure rate? Exactly the same, but look at the other 2 rows. The 7-day course had fewer side effects, and, this is the real game changer, a lower risk of creating antibiotic resistance. You get the same exact benefit with a whole lot less harm.
Now, does this mean long courses are gone forever? Of course not. There's still room for a doctor's judgment. If a patient just isn't getting better, or if there's a worry about a deeper infection like prostatitis, then yeah, a longer course might be the right call, but it's just not the default anymore.
So, let's zoom out for our final point and look at the big picture. What does all of this, new definitions, smarter prescribing, using data, shorter treatments, what does it all add up to for the future of fighting infections?
It really boils down to this single idea. This is about more than just fixing one person's UTI. It's about stewardship. The whole point is to cure the infection that's right in front of you, without accidentally creating a monster superbug that we can't treat down the road. It's about preserving our ability to cure infections for everyone tomorrow.
So let's recap the whole strategy. We start with a much sharper, symptom-based definition. Then we tailor treatment based on how sick the patient is. We use real-time data from cultures to de-escalate our antibiotics, and we do it all with a shorter, 7-day treatment as the new standard. And underpinning all of it is that one massive idea: antibiotic stewardship.
These guidelines are a massive leap forward, but let's be real. This fight is an arms race, and the bacteria are always evolving. So the question these guidelines leave us with is a big one. As the bugs continue to get smarter, how are we going to have to evolve our strategies to stay one step ahead?